Mm. Well, hello, everybody. My name is Peggy Reisher. I'm the Executive Director for the Brain Injury Alliance of Nebraska. And Kathy, I'll have you introduce yourself.
Sure. Hi, everyone. My name is Dr. Kathy Chiou. I'm an assistant professor at the University of Nebraska, Lincoln, in the Department of Psychology.
Yeah, and thanks for joining us here and listening to our presentation. What we're going to share with you today is just real high-level information about brain injury, as well as some simple strategies to when you're working with individuals with whom you're serving. And before we get started, though, we have this wonderful little QR code. They'll ask that you maybe pause the presentation, but if you could fill out this survey, it really is very helpful for us. There's a pre-training survey. It's going to capture some demographic information, and then you'll see a point on the survey that says, stop here and fill this out after the training. So we'll ask that you go ahead and put your phones up there and take our little survey. That would be great. However, if you need to pause, that's great. Otherwise, we are going to continue to move along with our presentation. So as we go through this presentation, we're really going to encourage you to be thinking about brain injury from a perspective of the lens of, is it a won't versus a can't? Oftentimes, after brain injury, folks seem to, make assumptions that somebody's being lazy, or they're not trying very hard, or that they're not very motivated. When in reality, after brain injury, folks are oftentimes dealing with deficit more so than defiance. And again, it looks more like that they're choosing to be, not compliant, when in reality, brain injury has caused them enough struggles that it's more of a can't. So we're going to start at the really high level. We're going to define what is brain injury. I think oftentimes people think of brain injury as simple as just it's the bumps, the blows, the car accidents and whatnot. And really what Kathy and I want to make sure you all are understanding is that brain injury has a much larger scope. Um, Acquired brain injury is a larger umbrella. It's essentially anything that's happened to our brain, which is not hereditary, congenital, or degenerative, that has occurred after one has been born. And so, this excludes those with developmental or intellectual disability. This excludes dementia, Alzheimer's, and things like that. But what it does include are the types of brain injuries we're looking at is folks who've had tumors or an anoxic or hypoxic injury, which means a lack of oxygen to the brain, infections of the brain, such as meningitis, strokes, aneurysms, ingestion of toxic substances such as carbon monoxide poisoning would be an example. Also, opioid overdose can cause brain injury. And then actually traumatic brain injury falls under this larger, again, umbrella of acquired. So my guess is everybody, as you kind of look at that list, everybody probably knows somebody who's potentially had a brain injury along the way. When we're looking at traumatic brain injury, as you can see in this video, it's the bumps, the blows, the jolts to the head. It can really disrupt that normal function of the brain. It also, we oftentimes hear people talk about, well, it's just a concussion. Well, a concussion is a traumatic brain injury. Whiplash can cause brain injury, as well as abusive head trauma, otherwise known as shaken baby. So as you can see here from this video, it doesn't take much to see how much our brains are jiggling around in our skull. And during those hits, what's happening is at a cellular level, kind of ripping and sharing of some of the neurons, and that's causing disruption and some kind of metabolic cascade, which causes problems within our brain. Oftentimes, these are things that are not going to show up on a CAT scan or an MRI when you see this type of hit. I want to dive a little deeper into something that you may be dealing with a little bit more within the regional centers, but strangulation or overdosing on opioids. We talk about, when we think of brain injury, I think we don't instantly think of this as being an issue. But what it is those anoxic injuries or those hypoxic injuries where there's that lack of oxygen to our brain can really hit our memory centers. And it doesn't take very long before, or very long with that oxygen deprivation for cell death to happen. And even though, it maybe doesn't look traumatic, it can have just as much of effect on our executive functions as a traumatic brain injury. So really to want to hit home that if you're dealing with clients that have had a lack of oxygen to their brain for a period of time through whether strangulation, overdosing on opioids, it could also be a suicide attempt through hanging. Um, Again, anytime there's a lack of oxygen. One of the things as I mentioned, sometimes these brain injuries aren't going to show up on CAT scans or MRIs. So really what we're looking for, what are the signs and symptoms? And not everybody will experience all of these signs and symptoms. So it's not like you just do a checkbox where you say, yep, they got, speech and language issues, organization issues, attention issues, and then it can be one or two things from each category, or there might not be, any symptoms in one particular category. But really what's the telling us about could there be the potential of a brain injury is you're looking for these changes in cognitive abilities, physical, emotional, behavioral. I would say that on the physical side of things, the things that we hear frequently are the headaches, the fatigue, and as well as the vision pain, as well as vision issues. I'm going to dive a little deeper into vision in the next slide. But on the cognitive side, it's that ability to get ourselves organized for the day. It's like the executive functioning skills. It's the things that really looks like a person's not trying very hard. On the emotional behavioral, when you look at these symptoms, given where you work, you're gonna like, well, gosh, Peggy, that's like 50%, or many of the folks that we're dealing with are also having these emotional behavioral issues. That's the reason they're within your facility. And I totally get that. But what we're seeing is that oftentimes there's a chance of co-occurring conditions, which is brain injury and the behavioral health issues. So just it's important to not always just want to lump it. I think we oftentimes want to lump it into it's a behavioral health issue. And it certainly could be, but could brain injury be a component of it also? On the vision, I mentioned I want to dive a little deeper. So of those, some research is showing of those with the traumatic brain injuries, the bumps, the blows, the jolts, 90% of them are going to have experiencing at least one or more visual dysfunction. So what is a visual dysfunction? That is not necessarily wear a pair of glasses. It's not an acuity issue of like farsightedness or nearsightedness, but what folks will oftentimes experience, depending upon where they're hit in their head or where they have their injury within their brain, it is, some will say that the words are hopping off the page at them. Some will say they're experiencing like waviness when they look at, for example, reading information. Some will have neglect where they might not see things in the peripheral, or there's maybe a portion of their vision in midline that is also shifted. So what's important is that we recognize that vision is a factor for those with brain injury. So there's times when it gets better, but for some there's some continue to be challenges. There are specific things that we can do to help support them also. So with all of those symptoms that I mentioned, again, not everybody has all of them, but we do know that they recover at different rates. So if you've got some cognitive issues that are lingering, but maybe the physical components have gotten better. So really, when we're looking for recovery, we're looking that all of the symptoms have gotten better, recognizing that just because the headaches went away, but you got the cognitive issues, doesn't mean everything's still a-okay. So looking at just recognizing that they recover at a different rate. Also, the good news with this is in relationship to mild traumatic brain injuries, the bumps, the blows, the jolts, is that majority of those injuries are going to get better within 3 to 4 weeks. Typically, like 80% of folks are going to have their injury and they're going to recover within a few weeks, which is great. However, we have the 10 to 20% of mild injuries that are going to require more time. And those that have more of a severe or moderate injury definitely are going to take longer than 3 to 4 weeks. So we got the good news, but the bad news. And oftentimes the bad news equates to brain injury now for me become a chronic condition. So if a person has had an injury at age 18 and now they're 35, that 20% might still be dealing with some of those issues at in their 30s. So also multiple injuries have a cumulative effect. So one injury is not great, two's not great, but definitely what we see, those with multiple injuries, it's kind of like a snowball kind of rolling down the hill. Just kind of more and more issues happen with multiple injuries, and folks have a harder time getting to that recovery level. I share this slide, just it is so important. You've heard me use the word mild injury. And what I want to really stress is that a mild injury doesn't necessarily mean it's not a big deal. It is for several folks, a mild injury can, again, have lifelong effects. One story I'll share here real just quickly is we have a former board member of ours. Her name is Sharon Royers. She actually wrote a book about her mild injury. It's called Out of the Rabbit Hole. If you're ever looking for an interesting read on what mild brain injury looks like, I think she's done a nice job illustrating her story. But she was a school principal. She hit her head on a cabinet one day in school. And one would think, well, that shouldn't be that big of a deal. But for her, it really was. She was a lady who ran marathons. She was very, very active with her grandchildren. She was kind of the height of her professional career, and just loving life. She had this hit on the head and it changed her life forever. She had gotten to the point where she ended up needing to take early retirement, and took her 5 years or so to be able to get to the point where she could run a 5K compared to the marathons she used to run. Anyway, it just really knocked her off her socks. So one would go, well, that's not that big of a deal, but it was for her, and she had chronic effects because of it. So we know that there's certain populations that are at higher risk for brain injury. If you're to check out the CDC, Centers for Disease Control, they're going to say general public, about 8.5% of the general public have had some sort of traumatic brain injury. In the veteran community, there's more. I think the last I looked, the numbers were about 20% of folks who are veterans have had a traumatic brain injury. With those within the correction system is research is showing about 85% of them could potentially have had a brain injury. Excuse me. There's one study done out of Colorado showing women within corrections was closer to 90%. We've also, Kathy and I did a project not too long ago with victims of domestic violence, and 58% of them screened with a potential brain injury. Again, you compare that to general public, those numbers are quite different. We've been doing some work within the juvenile detention centers here in Nebraska. Those numbers are ranging anywhere from 72%. I think there was one cohort of youth that we've seen as high as 86%. I also did some screening within a mental health program here locally in Lincoln, and found out that about 77% of them had indicated a potential for brain injury. So when you think of the individuals you're working with, have they been through some of these systems? Have they been victims of domestic violence? And if the answer is yes to those things, I think it's a pretty safe assumption that your likelihood of of working with folks with brain injury is also pretty high within your facilities. All right, and Kathy, I'll let you take it from here.
Right. So in terms of talking a bit about brain injury and behavioral health, Peggy, I'll have you advance the slide here. We know that with brain injury, some of us like to think that, oh, a lot of times this is just somebody who's going along life. They have a bad accident, they sustain the injury, and then they maybe recover and they go on, and that's that. I wish that were kind of the case for folks with brain injury, but the truth is that brain injury does not happen in a vacuum, right? There are a lot of things that could happen. There's a lot of other life stuff that goes on for somebody with a brain injury, right? You think about somebody, they could be coming from a place where there's a lot of environmental stressors. They could have relationship issues. There could be a lot of pre-existing issues that the person with a brain injury already had. Maybe they were dealing with some depression or anxiety. Maybe there was substance use, right? So it can create a messy picture. But what we know is that there's actually a lot of this messiness in brain injury, where there's a lot of co-occurrence of behavioral mental health issues and brain injury occurring. Sometimes you wonder, is it a chicken or an egg thing? Which came first? And the answer is actually both, right? So there's been studies that have shown that if you have a brain injury, you are actually more likely to develop a psychiatric disorder afterwards. You're more likely to have anxiety, depression, those things after brain injury. And then there are also studies that show that having a psychiatric diagnosis, so having a history of anxiety or depression or PTSD or any other mental health issue, can actually increase your risk of sustaining a brain injury. And so it's kind of cyclical sometimes too, in terms of what happens and what can lead to what. So what we do know is that there is a high overlap between brain injury and behavioral mental health issues. Next slide there. And for some numbers to look at in terms of how much are we seeing of issues of behavioral health and mental health cropping up in survivors of brain injury, the main line is that there's a lot more likelihood for somebody with a brain injury to also be experiencing these mental and behavioral health issues. So if you look at just mental health issues, we estimate about 19% of the general population will be experiencing some sort of mental health symptom or mental health issue. But we see that 30% of brain injury survivors are experiencing mental health symptoms after a brain injury. Looking at substance use, 7% of the general population. When you look at brain injury survivors, you're seeing 43% of alcohol experiencing alcohol abuse, 29% using illicit drugs. And so again, those increased numbers. And then if you look on the very severe end of kind of mental health symptoms, where we're talking about suicide, where somebody is choosing to end their life, we see that it's 4% in the general population. But what we know about brain injury survivors is that they are more likely to have suicidal ideation, to have thoughts about death. They are more likely to make attempts at suicide. And unfortunately, they are actually more likely to actually complete the suicide and die by suicide compared to the general population. So we're talking about some serious issues here in terms of when we're thinking about that intersection and what risk people with brain injury are at when they have these issues. Something else to consider is that these mental health issues don't just go away. For some folks, they will recover and their symptoms do alleviate, but for a lot of individuals with brain injuries, these mental health symptoms are persistent and they're chronic. There have been some longitudinal studies where they follow brain injury survivors, a couple of years, 5 years, 10 years, 15 years out from their injury, and they're finding that those with the brain injury, the symptoms aren't just going away. They're not dissipating. They're not getting better. And so it becomes a lifelong issue for these folks. Next slide. Right. In terms of thinking about why there might be some mental health issues and behavioral health issues that arise after brain injury, we know for one, there might be very naturally a psychological response to being in an incident or an event where the injury occurred, right? This might have been something that was very traumatic, being in a car accident or having to kind of pick up the pieces of somebody's life after having a brain injury. They might have to relearn how to walk. They might have issues with memory. They might have lost some family and friends because they don't like to go out as much after their injury, and that doesn't make for social functioning kind of deteriorates afterwards. And so somebody with a brain injury, adjusting to all of that, that could be hard. You would imagine that somebody might become depressed or might become anxious, right? But we also have to keep in mind that there is also a biological underpinning to some of these mental health issues, potentially. When you think about having a brain injury, you saw that video that Peggy showed earlier of the brain kind of shaking, right? And when that happens, a whole bunch of injury occurring to the brain tissue that is responsible for our ability to regulate our emotions. If you look at this picture of the brain that we have on our slide here, those structures that are outlined and highlighted in pink, as well as the front part of the brain, those are all parts of the brain that are responsible for helping us to control our emotions, to process emotional information, to regulate our emotional feelings. And so when those areas are damaged, we are not able to control our feelings as well, right? And so when you think about somebody with a brain injury, there is something kind of amiss under the hood, right, in the brain that is preventing them from being able to regulate their emotions in an appropriate manner. And so going back to thinking about when Peggy first mentioned at the onset of our presentation, is it a can't or a won't, right? Sometimes you might think, well, why can't they just pull them up by the bootstraps, right? Get your stuff together. You can, if you really worked hard enough, you could beat this thing. You could get better, right? But we have to remember the brain here has been potentially injured in this brain injury, right? And so they're not working with the full capacity that they can. And so it's not so much a won't do it, it's they can't. They don't have that capacity there potentially to be able to regulate as well as they'd like to. Right. Next slide. Right. So, in terms of thinking about brain injury and mental health, why is it important to consider this brain injury piece? Right. Behavioral health, mental health. That's already a hard enough issue to work with. Those of you who participate in treatment efforts know it can be a tough journey for those. Right. What happens when you add a TBI or brain injury on top of that? Well, it can complicate things in a lot of different ways. Right. There have been studies that have shown, there's this one study for PTSD. They compared those that had PTSD and then those who had PTSD plus a brain injury. They followed them out for a couple of years after their treatment and found that those with PTSD who received treatment were able, their symptoms they got better. The symptoms decreased and functioning improved and so forth. But for the folks with the PTSD plus the brain injury, they were not seeing those improvements. So the treatment efforts weren't as effective for those folks, and they were still experiencing the symptoms that they were experiencing years ago with the PTSD. So it can certainly complicate treatment, right? I think what this means is that we might have to think outside of the box when we think about interventions, right? When we think about traditional interventions that we use with our clients with mental health issues, we might think about psychopharmacology, think about medication, right? This can be incredibly useful for folks, for some folks with mental health issues, but this may not be as effective for somebody with a brain injury on top of things, right? Remember, this is a brain that has gone through some violence, it's injured, and so it may not be functioning in quite the same way as a brain that has not been injured. And so it may not react and respond to the medications in the same way. So therefore, it won't be as effective. Thinking about psychotherapy, I'm a licensed psychologist, a clinical psychologist, so I'm going to be a big advocate for psychotherapy, and it's great, a great tool. But if you think about the traditional, psychotherapy session, usually 50 minutes where you're talking one-on-one on very intense topics with your therapist, right, in a room. It can be tough for somebody with a brain injury who has attention issues, who can't focus, who can't keep that concentration, who fatigues really easily, or who has memory problems and can't remember to do their homework. And so psychotherapy might not be as effective for them, right? Or your traditional form of psychotherapy might not be as effective. You can think about psychosocial interventions, maybe groups. Support groups can be great when you have peers coming together and kind of, joining forces and being able to share with one another, and talk about lived experiences and kind of helping each other out. That can be great. But for somebody with a brain injury who may, after their injury, not quite have the ability to regulate their social etiquette, and may have communication issues, this may not be the most appropriate setting for them to do that work in. So all the tools in our toolkit that we usually think about pulling out for helping somebody with mental health issues, we may have to think a little bit differently about when we're thinking about somebody with a brain injury on top of all of that. Right. So we talked about brain injury and why it's important to recognize this brain injury in folks who may have mental and behavioral health issues. We'd like to give a little bit of a brief overview of a tool that we have that can be used to screen for brain injury, and that is the OSU, Ohio State University Brain Injury Screening Tool. And it is a really nice tool that is going to help you again screen for a possible brain injury. So it will indicate whether somebody has likely, might have, excuse me, I'm having problems speaking this morning, might have had a brain injury. It's not a formal medical evaluation, or it's not a medical diagnosis, but it is a screening tool that helps you figure out, oh, this is, they've met some criteria where it seems like they might have had a brain injury in the past, and that should raise up some red flags in terms of thinking about, potentially your interactions, your treatment efforts with that individual. It's a really nice tool. It's kind of, it can be used by anyone. You don't need to have any medical professional training beforehand. And it's actually set up as an interview. So you can kind of just go through the questions and ask the person about their experiences to figure out if there's been a brain injury. What it's going to look for are if there are events that have led potentially to this injury, and they get pretty detailed, right? What we've been finding before, or what the developers of this screening found before, was that usually when we ask about, have you had a brain injury, people will say, no, I don't think so. Because when people think about brain injury, it's usually, no, I never had a gash to my head, or I've never had a skull fracture. I've never, bled out of my head. That's not a brain, I've never had any of those things. I've never had a brain injury. But when you start asking questions about what could actually really lead to a brain injury that people don't think about, then they start thinking, and lo and behold, people start realizing, that could have been it. That time, in fifth grade when I was at horseback riding camp and I flew off the horse and kind of, fell to the ground, hit my head, and was kind of dizzy for a week. Oh, that might have been it. Or that time I was shoveling snow in the driveway last winter, and fell on the ice and kind of bonked my head. That could have been something. Yes. And then people are starting to realize those incidents could have led to an injury. So you need to it'll help to identify those incidents where a brain injury, where an injury could have occurred. And then it will also ask about any alterations in consciousness. So did you lose consciousness? Did you black out, and for what length of time? Or if you didn't black out, did you feel dazed or confused, or had any loss of memory after that incident? It's really that alteration in consciousness plus that event together that leads to a possibility of a brain injury. I think we've all probably bonked our heads at some point, right? That doesn't necessarily mean automatically you've had a brain injury. I would be in trouble if that were the case, being the klutz that I am. But it's really the combination of the alteration consciousness and the hit that leads to a positive screen here. So we've got so that is kind of the OSU screening tool in a nutshell. And I imagine that will be helpful for those of you who will be screening for that. Now, to switch gears a little bit and talk about strategies in terms of what do we do? How can we work with somebody with a brain injury, right? I want to start off by a case example. So this is the case of Sam. Sam is 33-year-old cisgender heterosexual white man. And Sam has a history of depression. He has some medical stuff going on. He has hypertension, diabetes. And we know that about 5 years ago, Sam was in a really bad motorcycle accident where he did sustain a brain injury. He arrived on the mental health unit about a month ago, and he's supposed to be going to treatment, individual therapy and support group for his depression, and he also takes medication 3 times daily. All right, so this is Sam in a nutshell. Now, what the staff are observing, the folks that work with Sam, this is what they observe of Sam, right? They say that Sam sleeps in every morning and he's always late to breakfast. Dietary in the kitchen always have to place aside, like a bagel or a muffin for him, or prepare a special plate after the kitchen's been cleaned up. It's kind of a pain in the butt. But he always wanders down late and is expecting to eat then when everything is closed up, right? Nursing staff have an issue with Sam because he's always skipping medication. He is nowhere to be found when he's supposed to come in to get his meds. They always they're always trying to hunt him down to get him to take his meds. So he's clearly not independent in that manner. In talking to his therapist, the therapist says that Sam isn't really making much progress in therapy because he seems to zone out during their conversations, and doesn't respond to their questions. When they sit there and they're asking him these questions, expecting a response, he just kind of stares and doesn't really engage, right? So therapist is a bit frustrated that there isn't much progress being made there. Sam is supposed to be attending support groups, right? But he's really quite disruptive during these groups. He talks out of turn, he interrupts his peers, and then sometimes after other folks have taken their turn and said their piece and said their comments, he'll just flat out say, that's stupid, or he'll make some other rude comment. And so he's really not doing great in group either. Others have said that Sam's also really kind of moody and irritable. He'll snap at housekeeping, cleaning, for trying to come in and change his bed linens and give him new towels. He'll come in and he'll just snap at them, and he'll just ask, what are you doing here? I didn't ask for anything. Why are you in my room? Right? And he seems to just not be very pleasant. So this is Sam overall, or what people are observing of Sam. And you can tell he's not the most pleasant person probably to be around, right? He seems kind of like a bad egg. This is the type of person you might want to try to get off your caseload if you're trying to work with Sam, right? Peggy, if you hit the advance, I think, right, people might see his behaviors as lazy. He doesn't show up to things. He's non-compliant. He's not taking his meds. He's defiant and rude. He's not engaging as he should, and he's moody and irritable, and just not somebody who you really want to work with, right? So unfortunately, this is kind of what Sam looks like, right? So in terms of thinking about Sam's behaviors, we take a look, though, a closer look at his behaviors. All these behaviors, they might actually not be the result of somebody just being an awful, mean, rude, impolite person, but they might actually be a manifestation of the difficulties, the cognitive difficulties that Sam is experiencing because of his brain injury, right? So for example, in terms of sleeping in every morning and is late to breakfast, he might not be lazy. It might be that he has a problem with his executive functioning. This is your ability to kind of organize and make a plan for your day and get going, right? And so it might not be that he is just being he's sleeping in on purpose, it might be that he forgets to set an alarm and he can't get himself up. And once he is up, he gets really confused about what to do. Should I shower first, then shave, brush my teeth, then go down? Or is it shower first, then shave, then brush teeth? What order do I do my things in? Right. And so he could be getting really overwhelmed by this morning routine and not being able to get that together and get down to breakfast on time. In terms of skipping his medication, that might not be Sam trying to be, a pain in the butt for the nurses, or being defiant. It could be that he has a memory issue and he can't remember when to take his medications or what medications, right? And so it's not that he's skipping out on them. It's just he can't remember. In terms of his seemingly non-engagement in therapy, it could be that he has issues with attention, right? Where he can't focus um long enough to sit in a 50-minute session with his therapist. His mind starts to wander, or he gets easily distracted. There's a window and he starts staring out, and he's looking at what people are doing outside, and he can't kind of focus on what's going on in front of him. It could also be a processing speed issue. Processing speed is a fancy term for kind of mental reaction time, right? How fast you can process information, and it could be that he just needs a lot more time to think about things and respond. And so his therapist is kind of sitting there expecting an answer right away when he's still trying to think about what the therapist said 5 minutes ago and processing that. And so everything for Sam is just kind of delayed, but it seems like he's not paying attention, or it seems like he's not engaged. The outbursts during group, right, or the rude comments, right? Um, it could be an issue with executive functioning. Executive functioning, in addition to kind of organization and planning skills, is also responsible for our ability to kind of regulate our behaviors, especially in the moment of doing something. So usually executive functioning allows us to put the brakes on, right before doing something. It allows us to stop and pause and think of, if I do this, what's going to be the consequence? If I do that, what's that consequence? Maybe I should do this and not that, right? It allows us to kind of inhibit ourselves to make the right decision. Executive functioning is something that's commonly affected after brain injury. And so in Sam's case, that regulation, that inhibition may have gone out the window. And so he will just act on a whim. Whatever comes to mind, he's just going to blurt out. He's not going to have that kind of social filter to be able to pause and restrict him and refrain from making those comments. This moodiness, this irritability and snapping at staff, right, for trying to help him. This could be a whole bunch of things. Some things that come to mind, maybe it's a memory issue where he can't remember, oh yeah, towels and linens are changed out every Tuesday and Thursday, and this is the staff member that comes in who is trying to help me with things, right? And so if he's really confused by all these people coming in and out of his room and he can't remember what they're there for, that can be kind of overwhelming and frightening, and he could be moody. So we can see, again, all these behaviors, while they seem on the surface to be just signs of somebody who is disengaged, who is rude, who is defiant, it really may not be that. It really could be Sam struggling with some cognitive issues, and this is kind of the resulting some behaviors that we see from that. All right. So in terms of thinking about what to do about this, right, with brain injury and these symptoms, I wish, and I think Peggy wishes as well, if we had a silver bullet, a special pill that we could give to somebody and everything would be fixed, that would be fantastic. But unfortunately, that's just not the way that brain injury works, right? The brain will recover and heal to a degree, but it's tough to say for everyone if it will go back to being completely fixed. So instead of thinking about how can we fix this person, then my approach, I like to think of it as approach to, well, how can we maybe change the way we approach working with this person or change the environment around them so that it better facilitates the things that they want and need to do, right? My example for this is, my 5-year-old kiddo. And if any of you have worked or have 5-year-old kids, you know that they are getting to that age where they like to be super independent. Everything they think they can do on their own, they want to do on their own. They don't want any help at all. And so they're very gung-ho, or at least my kiddo is very gung-ho about doing it himself. Right now it's getting snacks for himself. That is the thing that he likes doing. And my kiddo is tall. I think we took him to the doctors and he's like 99th percentile or whatever growth, but he is not quite tall enough yet to reach those snacks that we have up in our cabinet. And so I walk into the kitchen, see him stretching out for those snacks, trying so desperately to reach them, but just not making it. Now, me as a mom, I could stand there at the door frame and just say, sorry, buddy, it looks like you're really close, but I think in a couple more years, when you grow that 2 or 3 extra inches, you could probably reach those snacks, right? When you're 7 or 8, you come back for those snacks then, right? I could do that, but I think that would be, I would not be winning any Mom of the Year awards. That seems like a pretty crappy thing for a mom to do, right? So instead, I'm thinking, what can I do to help my kiddo get these snacks? And how can I empower him to since he likes to do this stuff on his own, right? So I think about what changes can I make to our kitchen, right? Can I place a step stool next to the cabinet area so that he can get out a step stool when he needs to get the snacks? He can step on there and get the snacks himself. Or, can I maybe move the snacks down lower onto the counter where he can reach so that he can reach them himself? And that way he feels great that he can do it himself and he's empowered to do so. And I'm not expecting him to, just sit there and grow the few inches, right? It's changing the things around him to help him. I think we can think about that same approach for folks, or when we're working about strategies to work with when folks have some cognitive weaknesses. So we have a few to share here. We can go through. First, in terms of dealing with the sensory symptoms. So thinking back to that slide that Peggy had up earlier, one of the areas that folks have issues after brain injury. Is with bright, harsh lights. I'm sitting under some fluorescent lights right now that are pretty glaring. That can be kind of uncomfortable for folks with brain injury. And so thinking about your lighting source, I should probably get in a more kind of nicer lamp or using, natural light or something that is a bit more dim than the bright fluorescence. Thinking about noise, when there are loud noises, it's hard for anyone, I think, to concentrate, but especially for somebody with a brain injury, that can be really overwhelming and distressing. And so thinking about a more quiet location. I know sometimes it's hard to do that, maybe in the settings that you all work in, but trying to kind of, or maybe finding downtime where it usually is more quiet around the building or whatnot to do some more to do work with might be helpful. Thinking about attention. So folks with brain injury have a really hard time focusing and concentrating on things. And so things that could help with this is to reduce any distraction that may be around. And so, if there's a window that leads that looks out to this beautiful area, maybe having to close the shades on that to keep focus in the room. For me, when I work with clients, I need to clear my whole desk. I have a ton of little knickknacks and pens and piles of paper. I need to just clean out my whole desk, swipe everything aside so that there is nothing in front of me, right? It may also be helpful to use cue words. And so this is cueing the individual to know that something important is coming up and they need to pay attention and latch on to that information. So if I'm telling a client that they have an appointment next week at 10 o'clock, I will, before getting into that, I will cue them and say, now this is a really important piece of information. I need you to listen. Your appointment is at 10 o'clock next week, right? So I will cue them into the importance and need to kind of pay attention to that piece of information. In talking about processing speed, again, this is, that mental reaction time or time it takes for you to process information. After brain injury, it's common for this to be slowed down. So everything takes longer for them. So you'll want to give the person that you're working with additional time to work on something, right? And also to prioritize tasks that you may be doing with them. So if you have a list of 10 things that you're trying to get done with this individual, prioritize what are the first, what are the top 3 things that they need to get done that day and focus on those things, right? Something else is to just speak a little bit slower with them. I know for myself, I tend to talk really fast, or the more excited I get, the faster I talk. So this is something I have to watch out for overall, I guess, but especially when I'm working with clients with brain injury, just to slow things down for them so that they have that time to process that information. With communication, sometimes folks with brain injury have a hard time understanding what's being said to them, and then they can also have a hard time expressing themselves as well. In terms of having them being able to better kind of comprehend you and to get what you're saying, you want to use direct messages, very straightforward messages. Don't use kind of that indirect type of approach. So, for example, when I'm sitting there in the house and I'm freezing in the winter, I will look to my husband and, kind of shiver and be like, hey, it's kind of cold in this room, right? With the implication, like, can you turn the thermostat up, turn up the heat a little bit? You don't want to do that indirect kind of messaging. You just want to say, hey, turn up the thermostat, please. All right. Be very direct and straightforward. In a similar vein, you want to try to avoid sarcasm if you can. That is sometimes something that is, can be a little abstract and requires kind of reading between the lines. That sort of thing, sometimes folks with brain injury have a hard time with. So you'll want to kind of avoid that if you can. Checking in for comprehension of what you've said is also helpful, because sometimes um, you may be saying something, but it's not registering with the person with the brain injury for whatever reason. Maybe they are thinking about what you said 5 minutes ago, or they just need more time. But they may be embarrassed to say so. So it could be that, we've all been in situations maybe where somebody's talking to us, we have no idea what they're talking about, but to save embarrassment, we kind of nod and smile and go along with it. And once the person has left, we're like, oh, dang, I have no idea what that person is talking about, right? That could be the experience for somebody with a brain injury. And so to check in to make sure that that person is getting what you're saying, you can, ask them questions about what you just said to make sure that they really got it, right? So back to that example of that 10 o'clock appointment that I need for my client, I can check back in and say, all right, so what time is your appointment for again next week? 10 o'clock. All right, they got it. Good. And if they look lost, then repeat yourself. Memory is another biggie in terms of symptoms that folks with brain injury have difficulty with. And it's not so much the past memories, like what was their, you know, um, first job that they ever held, right? Or their name of their first, girlfriend or boyfriend or who have you, right? It's going to be that new information that they need to learn, maybe new names or new routines or things like that they're going to have problems with. So some different things that can help is, repeating things over and over. I know it might get really kind of, you feel like you're listening to tape recorder or something on repeat, but just do it again. It helps for helping to get that information to stick. Similarly, having routines, talking about, repetition, all of that in terms of the less that you have to have a person remember to do new things, the more helpful that can be. Or sometimes using memory aids, things um, that can lessen that mental load, right? If they can write something down somewhere, or use, technology if they have access to a smartphone or an alarm or something that they can set alarms for, that can be helpful. And then finally, with executive functioning, being able to kind of organize and plan things is sometimes having a whole lot to do for somebody with a brain injury can be really overwhelming. So something that can be helpful is to break things down into simple steps, right? Very concrete, step-by-step kind of um, instruction list for them to do rather than something that's big and abstract, right? So rather than saying, why don't you go get yourself some lunch, right? Break that down into, okay, go down to the kitchen, grab a plate, grab the bread, grab the ham out of the refrigerator, put the mayo on, step by step, break it down for them so they have a real clear list to follow, right? And then finally, for some of those emotional issues that you might see, sometimes this is just fatigue or frustration. So suggesting breaks, mindfulness, some of that can all be helpful. Right. So in terms of thinking back to our case of Sam and his behaviors, there's probably several different things we can think of that we can do to help him with some of these behavioral issues, right? Again, it's not him being a bad egg and trying hard to be a pain, but more so, if we can help him with some memory things, if we can help him with some of the processing speed issues he might be having, some executive functioning issue things, then maybe we might be able to empower Sam to kind of do the things that he needs to and wants to do. I think we have a couple slides here on more strategies. I know I went through several, but we have a resource from the Brain Injury Alliance that tells you about kind of what cognitive area there might be some issues with, what it might look like, how it might present itself kind of day to day, and then some more management strategies that you can use. And I suppose, yeah, you can probably pause this to read, rewind and pause this if you need to, or I think Peggy, I'm sure you could probably get resources out to folks. I know this is usually on one of the flyers that we hand out for our in-person sessions.
All right. And then for some online resources, Kathy, was there anything more you wanted to say about
Nope, I think that was it. Yep, hand it back to you.
So if you're really thinking, oh my gosh, this is fascinating information, there is a whole host of additional resources, a lot of them through SAMHSA that give you more information about brain injury and how to serve those with behavioral health needs. So if you are interested, feel free to go. The NASHA website at nasha.org has all of these articles. It's great stuff. There's also this link to Beyond Brain Injury. What I really like about this particular document is it kind of asks, like, how is it, what's your role within the organization? And if so, here's some further information that might be of interest to you. So it does a really nice job going a little bit beyond just what you're hearing today with Kathy and I with our Brain Injury 101. So feel free to take a look at that. Connecting with local resources. We here at the Brain Injury Alliance of Nebraska have what we call resource facilitators, which are essentially staff members that provide support to individuals and family members with brain injury. We also provide a lot of brain injury education. We get people connected to support groups, to peer support, to other community resources. We spend time talking with community resource programs or community resources about brain injury. So we're doing what we can to educate them about brain injury too. So let us know if we can be of any help to you. Our services are free. We are grant driven and we are across the state. So I have resource facilitators that cover every part of the state. So give us a call, check out our website. We're here to help you. We recognize that you're not going to learn everything about brain injury in an hour presentation from Kathy and I, But we are here to, again, be a help to you down the road. And this is our post survey. If you were so gracious to fill out our pre-survey, go back to your app and finish taking the survey. That would be greatly appreciated. Your feedback is very much valued. And that is us. So feel free to reach out to us should you have any questions. I know when we're doing this in person, it's always nice to be able to answer a few questions, but since you're getting the video version of it, we're happy to be a resource for you after you watch this should you have any questions. Kathy, any final comments?
I don't think so. We're good. Thanks so much for your time, everyone.
Thank you.